Great. Welcome, everyone. Welcome to the Future of Mental and Behavioral Health. I'm Bambi Francisco Roizen.
And this is Archana Dubey. We are here on a breakout session and welcome all of our esteemed panelists to have a robust discussion today around mental and behavioral health.
Yeah, and before we kick this off, I do want to thank our sponsors. So BetterHelp, which is a provider of virtual therapy sessions, Octave Health, which is a provider of in-network virtual therapy sessions as well as in-person therapy sessions, and NeuroFlow, which is a collaborative platform software company that connects primary care physicians and providers such as psychiatrists and therapists and others who are in the care, supporting care and for those who are struggling with mental health, as well as UCSF Health Hub. They have been a partner for 3 years and they'll be hosting our event in November live. As well as Advisor, which is an M&A advisory platform, StratPoint, an outsourced engineering platform, and Scrub, which provides outsourced bookkeeping. Also, for those joining us, please have your questions teed up and put them in the Q&A or the chat session. We will be opening this up around 3:45, so you can direct your questions to all of us and particularly the speakers. So be prepared to be part of the discussion. So with that, I wanted to just provide some context with regards to this conversation we're having today. Archana and I have been hosting the Future of Mental and Behavioral Health since 2018. So we've seen a lot that's happened. This is our 4th annual event. It's one of the most popular events that we've been hosting under the Invent Health series. So there's 3 points I want to bring out. 1, there's new factors contributing to the rise of mental health. 2, there's still a big challenge that remains before us. And 3, COVID was a silver lining. So number 1, new factors contributing to our mental health. Obviously, COVID and the pandemic, it's given rise to these fears of losing our life, our livelihood, our minds, and potentially family members. It's been a tough year, but there's also other factors contributing, and that is this sort of culture war, which might even be a little bit even tougher on us. And so I have written that half of the country believes the picture of this painting of the country we know is fading into the past, and the other half feels this painting of the country we know has always been a fraud and isn't fading fast enough. And my friend Peter Thiel likes to describe the polarity as half the country believes that race is on a spectrum because many of us are multi-ethnic and gender is binary. And the other half believes that race is binary and gender is on a spectrum. So these sort of epistemological, views, the challenges that we have before us is really weighing on our sanity levels. So that's the rise of our elevated, this is contributing to our elevated stress levels, and those aren't going away. The big challenge before us, we have a healthcare industrial complex that is oriented around identifying illnesses before we get paid. And this is not a slight on the healthcare industry. It is just a matter of fact. This is the way the medical ecosystem and infrastructure has been established. And the unfortunate unintended consequence of this is sort of this ever-expanding definition of what is illness and who is sick. And that is a challenge as we move toward preventative care when most people aren't sick, right? And that is where we actually need to start treating more people. And the third is COVID and the silver lining. I heard someone say that we cannot have preventative care until we have telehealth, and telehealth brings on preventative care. So that is a silver lining. COVID was a travesty, but it was also a forcing function for telehealth, and that is actually a good thing. And so now we've actually started to see providers not only embracing telehealth, but new care modalities like Vator Health is showing that it can reverse diabetes, not through medications, but through behavioral sciences. And I think the industry is now realigning themselves or reorienting themselves to understand what behavioral science and therapy can actually do. And it's changing the way we think about how we care for mental health. And those are good signs. And so hopefully this conversation will be around how are we reorienting, how are we changing the way we view mental health, how are we changing how we think about paying for it, and increasing access. And that's going to be the discussion for the day. And again, at around 3:45, 4 o'clock, we will be opening this up to the audience as well to come in and have your questions directed to our speaker. So with that, I'm going to hand this over to Archana.
Hey, thank you. Thank you, Bambi. That was such a good overview of the drivers that we are seeing in the last year and a half, actually coming to a head in the last year and a half. They have been brewing in the background for a very, very long time. And that brings me to our esteemed panelists who have either created innovative models or are powering up the innovative models by buying them and scaling them in their organizations. And so I want to welcome Kate from Optum Behavioral Care, Eva, Sandeep, and Marjorie. And I was thinking I'll introduce everyone, but we'll do it our Invent Health style because I cannot do a better job than you yourself. So I got the Zoom window in front of me, and I have tiles of like faces, wonderful faces all around of my panelists. I will go around and then have you introduce yourself, the companies that you represent and what you're solving for and what your philosophy is around mental behavioral health and how are you helping your customer. And please define your customer too while you're doing that. So Sandeep, I see you as the first on the right. And if you could kind of share what you're up to.
Sure thing, and thanks for having me. My name is Sandeep Acharya. I'm the founder and CEO of Octave Health. We're a mental health practice that employs therapists and coaches, and our mission is to create access to better quality therapy and coaching services in network, primarily working with payers. Today we're in California, New York, and expanding across the country. There was a couple questions in there. I want to make sure I got all of them. So was there anything else you wanted us to cover in the intro?
Yes, and share about who are your customers. So you did share about you're serving the patients, but also like, do you sell into the payers or self-insurance? Yeah. Like, yes, those would be important.
Yeah, it's interesting. I think it's really important that we work with payers, but our clients first and foremost are our clients, and good care is kind of at the essential part of kind of what we're doing. I think a secondary client for us would be the providers of care. Therapists these days are in very high demand. There's lots of ways they can use their time, unfortunately, because of the need that exists. So we are thinking really hard about how to support them in their best practice.
Excellent. And I see Marjorie next on my slide deck here.
Well, thank you so much for having me. I'm Marjorie Morrison. I'm the CEO of PsychHub. I spent about 15 years in private practice as a psychotherapist. Sometimes I forget that I ever did that, but it definitely informs and has kind of made me passionate about the work I get to do now. And then I spent about 10 years working with the military and writing proactive counseling before I found myself in online education. And PsychHub does online education in all mental health topics. So we have a variety of different ways for people to learn, because I think everybody learns differently, and the model of online education is a little outdated because you kind of take something and then you don't retain it and you forget it. So we just have a bunch of different content. So we have courses and we have short videos, people who need quick information, and text-based for people who like to read, podcasts for people who like to listen when they learn. So I think we get to see it as we get to support all the really great work that so many people on this panel do. We don't do any of that direct care, but we just are kind of helping amplify it with education. I don't know if that helps, if you want me to go more, or is that good?
Yeah, that's fantastic. And we'll dig deeper as we keep questioning each one of you. So Eva, can you please introduce yourself and welcome to the panel?
Yeah. Hello, everyone. I'm Eva Borden, and I'm the president of behavioral health at Evernorth, which is the health services company for Cigna. So when I think about what it is that we do, there's really a few main points for behavioral health. That's number one, how do we make sure people get access to care quickly? How do we make sure we can triage and navigate them to care? How do we help manage the really high cost behavioral health needs? And ultimately, how do we integrate medical, pharmacy, and behavioral health together? When I think about who it is that we're serving, it could be anyone who is purchasing within the Cigna health plan. It can be health plans who want to purchase independent to integrate behavioral into what they do. It can be direct with employers. It can be partnerships with providers. It's really anyone in the behavioral health space. And our main focus and goal is that ultimately, if I think about what it means to create sustainable healthcare in the United States, we have to be able to treat behavioral health in a meaningful way and not put it off to the side, not neglect it. But really, sustainability is going to be about how effectively we can address the mental health needs of our population.
Excellent. Thank you. And Kate?
Kate Hobbs Knutson. I'm a psychiatrist by background. I've been in the payer space for about the last 10 years across Medicare, Medicaid, and commercial. I've been at Optum for about the last year, leading Optum Behavioral Care, which is what it sounds like. It's a care delivery company focused on outpatient mental health and substance use treatment. The idea here is to be able to stand up this kind of treatment anywhere in the country, work very closely with partners, just like the people here on the phone, on the video, to be able to improve access, quality, and overall health outcomes and costs through this high quality outpatient behavioral health care. Our customers are people, so the members that we serve, again, across Medicaid, commercial, Medicare, certainly employers who are seeking better access to mental health care for their employees, and then certainly states and federal agencies. So I'm very excited to be here today and part of this conversation. Thanks.
Thank you. Thank you. Off to you, Bambi.
Yeah, thanks to everyone. And the big, I think what everybody touched on was access. And of course, at the center of access is the therapist or the provider. And so I want to start off with Sandeep, because your organization essentially gathers, employees, providers, and therapists. But as we all know, many of these therapists or psychiatrists, psychologists, many of them, more than 50%, are in solo practice. So I'm curious, how are you able to attract these providers who typically want to be in a solo practice?
It's a great question. And I think it's also important to note that while our conception of all therapists are that they work in solo practice, there are a number of them that work inside of nonprofits and community institutions and hospitals that are looking for stable incomes and good case mix, good case work, and good support in the work that they do. And we seek to employ those folks. But we do actually also employ folks who may otherwise work in private practice. And I think particularly in the markets we serve, California and New York, there's a little bit of a trade-off between affordability and sustainability. Right. And so if you're a private practice psychologist, you can charge a couple $100 a session, treat folks who will take your cash pay, not deal with any insurance hassle, and be fine. But I think therapists are inherently altruistic folks, and they want to find ways to help people in need. And so we really try to help them by providing competitive compensation. We've negotiated deals that allow us to be able to compensate therapists more. And as a result, they don't have to make that trade-off between where the need is and have sustainable incomes. And so that's what we really do. We really try to provide them a case mix of folks who really need the care, working with insurance companies to get folks in network, bringing folks who otherwise wouldn't be able to afford the care, and therefore do it at attractive wages that they can actually afford to provide it, while removing a lot of the hassle, right? Navigating deductibles, navigating eligibility benefits, navigating a lot of the bill submission and denials that come into play. We take care of that as a company, so that therapists can just focus on good quality client care.
And you focus on California and New York, right? That's where your therapists are in network. That's
where we are today. And yeah, just for context, in those two markets, the average cash pay price, if you look on the networks, is a couple $100 a session. When insurance rates are typically $100, it becomes very hard for those therapists to accept insurance when there is such a thriving cash pay market. That's what we try to solve effectively with some of the value-based contracts we do with payers.
Is it true that across the country, on average, the therapist is making about $30 or maybe even less than that an hour?
$30 an hour. I mean, certainly Optum and Cigna can tell you better than I can, but no, it's actually, as I understand it, closer to between 80 to 100 in network, and it varies on a cash pay basis anywhere between 130 and 200 depending on the market.
Yeah, and I think Bambi, you might be coding like take home, like net, whatever it is, because that could also have overheads like liability insurance and other things that they could be paying out of. And I wanted to extend that same question to Eva and Kate, because you are also having network of therapists that you're either paying for or managing. How are you building that network? Because, we got the cash market, we got Sandeep, who's taken some of those therapists. And like, are you getting good quality? And how can you put quality matrix if the folks that are willing to work with maybe a little bit more subsidized rate now have more requirement to kind of get credentialed with larger insurances? How does that work for you? So Eva, I could begin the question from you, and then Kate, you could kind of also follow through on that.
Yeah, so when I think about the focus on driving access, I think it's a really, really important part, and something that we're actively recruiting providers to add into the network and bring it in and make it easier. Because I think a really important piece is there might be this misconception that, well, payers just want to make it difficult, that we exist to make things difficult, and that's not actually the case. We're really working hard to partner and make the experience easier with providers, as well as easier for our patients to find care. I think one of the things that we've talked about before is that oftentimes as you think about bringing in providers, there's a concept that, well, just any provider will do. And that's not the case. It's not about, so I often use the example where it's not like having an ear infection where I go see my doc, I get an antibiotic, and I walk out and I'm okay. And in that case, I may not remember the provider. If I walk past them on the street, I wouldn't recognize them, and I probably don't even know their name. But when you think about therapy, there's the match that goes beyond, does someone have the background, and is the individual, what are their needs? And making that match becomes really important. So it's not just a one-for-one in a network where, gosh, if I have a PCP and I have an individual, check, network access, I'm done. That's actually a lot of what we're looking about cultivating in our network, is making sure we can meet the diversity of needs and how people want to, whether it's by gender, sexual orientation, racial needs, ethnic needs, et cetera. So it's kind of like that whole aspect of growing the network, but doing it really thoughtfully. The second part is, I really appreciate what Sandeep is doing. There's a number of others in the space that are really advancing measurement-based care. I know that's a real passion of Marjorie's. So when you think about measurement-based care, our ability to measure quality, to advance how to measure care, that's actually one of the best parts of virtual care, is it enables easier ways to capture information, measure changes, measure different quality components, and then you can get into the quality on the more intensive levels. But when I think about it, if I were to just kind of summarize, advancing and adding to the network is extremely important and a top priority. How we do it is really important to make sure that we've got the diversity, so that way when someone has a need, we're able to find someone that's a good match. And three, focusing on how do we advance measurement-based care, because it's not just getting someone care and you're done, but how can we actually show differentiated outcomes? And if I go back to my North Star on driving affordability in the healthcare system, I have to be able to have and demonstrate that.
And how about you, Kate?
Go ahead, Kate.
Are you encountering needing to squeeze the group of network to kind of have quality and cost outcomes? And how are you getting that network enrich itself?
Yes, and completely concur with everything that was just said. Really, really well stated. Two things I'll add. One is picking up as well on what Sandeep was saying, is paying providers differently. So I often say that basic fee for service really breaks good mental health care. By definition, good mental health care requires a team. We need to be collaborating across mental health providers, primary care providers, health coaches, if you're working with children and youth, schools, families. And it's really hard to do that, high quality team-based care when you're in a fee-for-service environment that requires, the face-to-face visits and in order to be reimbursed. And so moving away from that aggressively towards more population-based payments that are linked to access and quality. So the point that Eva was just making, measurement-based care is incredibly important. Being able to actually, use those outcomes in the course of treatment, but then also be able to report them for differentiated payment is really important. The other point here around, making sure you have an adequate network is acknowledging that we do have a provider shortage internationally. And it's worse for special populations like children, geriatrics, some racial and ethnic minority populations. And so figuring out how to extend that limited resource through telehealth and also really turning care delivery on its head. How can we use digital in new ways? How can we use a varied workforce? Not everyone has to be an MD psychiatrist, right? Like we can use lots of different people to help form relationships that can extend the care team. And so being very creative about, like you were saying, how do we match the need here with the right resources that will make that important connection that will help with behavior change? I think it's really important to be creative there.
If I could jump back in, it's interesting because you hear the same 5 or 6 things on opposite sides of the table, right? It's like, one, we all agree things should be covered by insurance because it's greater equity when you have things covered by insurance. We all agree measurement-based care should be happening, but only 2 in 10 providers are doing it. We all believe that there should be multiple options for delivery. One of the things that Kate did mention we're big believers in is coaching and group as means of extending our delivery system. We would probably implicitly agree, but haven't said it yet, that we believe in dissemination of evidence-based practice, right? So no crystals here. There needs to be sort of proven methodologies wherever possible. And certainly Marjorie would agree with that. Integration with primary care is another thing that we all discuss, but harder to achieve in practice. And then a slow evolution of payment models, but it's like the how that ends up getting really tricky on those things. To throw a thorn in the side of the agenda, I mean, do we have enough scaled players to really accept the kind of value that Optum wants to have, or are we in an early phase of kind of getting to scale so that we can be more creative longer term? And how are providers really incorporating these measurements? That's one of the things that we've been thinking about on the delivery side. We can't just put the measurements in front of the patients and hope the providers do something about it. We've got to actually integrate it into the software. There's a lot of complexity in actually executing on this that I think we're all tackling right now.
Do you feel, and question for all 3 of you, do you feel that the licensure bound by state borders is something that's bottlenecking this expansion of virtual care and other things, especially the network effect? Because there's geographic clustering of providers that happens, and so it leaves a much bigger area of the country somewhat uncovered with quality providers. And personally, I've seen in the primary care space for sure that this emergency expansion of licensure was extremely valuable for us to extend network and utilization and capacity of our providers and my clinicians. And that's something that I wanted to ask you, and I've always been curious, is that impacting your network advancement? And anybody can pick the answer, but maybe otherwise I'll do the name calling here. And Marjorie, this is open for you too, because you do have that.
Well, I mean, I would think that the impacts are pretty great. I mean, there's so many different types of mental health providers too. So when you even think about the state boundaries, you're looking at PhDs and social workers and counselors. And I think to everyone's point, the shortage is just the shortage. The need is great. And that there's not enough providers. They're very burnt out too. So we got I don't know. I don't know if I can really answer the piece about the shortage so much. I know in the military space, that was a really big deal. So I don't know if Kate or Eva want to comment on that, but I would love to comment on really this piece about what I think would be quality care, that when we're really delivering quality care, evidence-based care and measuring care, we get providers through treatment quicker, more precision therapy, and that does open up. And then I just do totally agree with this access issue where we really have to start looking at, I think it was Kate it was either Kate or Eva said, like the different tiers of help. Not everybody needs to see a licensed mental health provider. I think we need to kind of move our own thinking around that to say that that doesn't mean that we're not getting good care. Care looks different to different people at different times.
Now, when I think about, to me, I've seen less of an impact from the licensure changes as much as just having people adopt virtual care. It was this kind of pre-March, you'd see this 1, maybe 2% using virtual care, and then silver linings from COVID, all of a sudden you saw this acceleration. Well, where I saw it happening more and effectively was actually addressing some of the rural needs around care, where all of a sudden, if you think about driving, and I'll give you just a prime, like I'll make it really personal for a second. I have a daughter who needs regular behavioral health care. And so given where I live, her provider's an hour away. So all of a sudden now it went from, I have to take her out of school, I have to drive an hour, have her be seen for an hour, get her 15 minutes with a psychiatrist, an hour drive home. And oh, by the way, I work a full-time job. And so now all of a sudden it came to the point where she could come home. And the most fascinating part to me that I thought was really interesting in terms of opening up is she would almost be, we would get into having her conversations with her therapist and she would barely engage. And when she was home, she all of a sudden started engaging more. So I was listening at one point, and it's not that I could hear what she was saying, but she was animated. And I started having this conversation, trying to dig in, why what's going on? What's different? And she's like, well, Mom, she's in my room. She's in my space. I can talk to her now. And it was all of a sudden for someone who going somewhere different introduced a whole nother level of anxiety. It decreased it. So back to your specific example, for me, it was less about the cross-state licensures. And it was about just generally opening up access much more broadly with a lot less friction and making it just easier for people to get care. And we actually saw that play out in the numbers that once virtual care came into play, we saw more people sticking to actually getting care and getting more appointments than we did before.
Yeah, our no-show rates dropped, our NPS didn't, and we've seen more reliability amongst our clients, very similar data.
Similar here as well. Yeah, go ahead.
No, I'm just kind of contrary. I think it is the virtual care, even in primary care, we have seen that across all lines, yes.
And also the stigma issue as well. I mean, imagine that you're in a small town, everyone knows your car. You don't want to go be seen in front of the mental health clinic due to stigma. There's a whole other level of privacy that people have through telehealth, and to the point, especially if you're an hourly worker and it's hard to get off or at work. I mean, you can use your lunch break. So it's really been a game changer for people.
It's interesting because everybody here talked about measurement care. I think that's the words that you used, Eva, advanced measurement care. I'm not quite sure, or evidence-based protocols, something like that. And prior to 2021, I think last year, 2019 for sure, I believe, Archana, you and I were talking about evidence around telehealth, right?
Yeah.
We need to measure the efficacy of telehealth, and here we are saying, oh, it works. So I'm wondering if there's other...
We did what, future of clinics, and we were talking about
everything is about efficacy and measuring telehealth, and here we are. It's taking, we're taking for granted telehealth does work. We don't have to measure it anymore. And I'm wondering if there's any other modalities out there that we are just holding back because we need more evidence, similar to telehealth.
I mean, I think part of it is just that when you get trained as a therapist, things change over time, but we don't really change the way that we deliver care. And it's just kind of, it's the whole system. The whole system's a little broken like that, right? So we don't, I'll tell you, when I got licensed, I never learned about evidence-based interventions. I had no idea that there are different ways to treat different symptoms. I treated everybody the same, and I'm embarrassed to admit it, but I didn't know any better. And I would have told you my clients were getting better, but they would come back and they would come back. And now I've learned so much about just really more precision therapy, that how effective evidence-based, how you treat insomnia is very different than how you treat complicated grief or even anxiety or substance use. And so I think a part where we're holding back is that there's just obviously I come from the lens of training, but there's a real sense of having behavioral health providers be more specialists, focusing in and honing in their craft, working with the same types of clients so that they're getting better. We also know it really decreases burnout. So I would say like that, obviously from my perspective, that's kind of the next wave, is really trying to move people to do like what Eva was saying, that really precision matching is so key, because when people do go get help, we want to get them the right help, right? And they don't have a lot of time to go talk about what happened to them in 5th grade. Maybe that's, now they just need to have the skills and whatever it might be. So that's my perspective of where we might be holding back, of where this kind of next generation could take us.
Yeah, I think that's a great way to think about it, sort of precision therapy. So if we can just break that down for us and for those who are listening, let's talk about that, Eva. Let's talk about what, the measurements you're looking at, or what you call measurement care. What, what kind of, let's look currently, not what your wish list of what you want to see, but currently what data are you looking at right now that shows that the care you are supporting, paying for, is actually yielding a benefit?
So I'll go, and then Kate, I'm sure that you or Sandeep will also be able to add in here too. So when I think about, for us, measurement-based care, this is a lot of where, and I know when we think about the audience that often listens in, when you think about the advancements of, oftentimes anytime there's a digital play, there's an ability to measure it, whether I can measure my PHQ-9s, my GAD-7s, things like that. That's kind of in the traditional measures, to be able to have them, record them, and know the movement over time. I actually think there's even more that we can do in this space, because the challenge with behavioral health is I can't take blood, urine, or tissue and say, okay, you were this, now you are this, check, you're good. Like, it doesn't exist that way. So what are the other tools? And I've seen a lot of exploration around what that could be, what it could look like. I think digital is going to play a really important part. I also think part of what we do is understanding, gosh, if I know someone's had some type of care, when I also am able to measure the difference between where they started and where they're ending, and then to really wrap around and understanding the difference in medical and behavioral spend, medical, behavioral, and pharmacy spend, it becomes really powerful. And that's actually what I think we need some of the migration from. It's great we're all talking about behavioral health. I feel like we've advanced from this conversation around behavioral health into well, now it's a wellness benefit. So yeah, I have to provide it because of parity, I got that thing. But it's kind of taken on this wellness benefit feel, as opposed to, no, it's actually a real, true component to all of healthcare that we have to help treat the full patient. So I feel like we're moving along the spectrum, but we're not totally there. I kind of went, so on the measurement base, there are pieces. It's a matter of looking at the traditional measures, advancing them. How do we look at the total cost? But then there's also this piece of collectively, how do we move beyond what sounds like the sexy little wellness benefit into something much more advanced and precise?
Kate, did you want to, you're nodding your head. Did you want to add?
Sure. And the question was, how do we measure quality today? And the reason that I smiled is it is very limited. And the fact is, by and large, most reimbursement for behavioral health in the country is again basic fee for service, without any sort of measurement of quality or any differentiation in the payment based on quality. Our most robust measures are symptom checklists. So things like PHQ-9 for depression, GAD-7 for anxiety. These are great, yet as Sandeep was saying, incredibly hard to collect. They're basically surveys, right? So just like it's hard to fill out a survey when you go anywhere, it's very hard to have a patient fill out this survey routinely. And then it's really hard for clinicians to actually get that information back so it's available in real time. And then also, again, be able to report it in aggregate back to a payer. Most behavioral health providers actually don't have robust EHRs. Many were left out of the HITECH Act, so didn't benefit from the investments and the finances to actually get EHRs. And so imagine trying to, across your patient's panel, month after month, collect these surveys and get them into the point of care. It's really challenging to do. And then the only other pitch I'll put in there is that I'm ready to move even beyond surveys. So there's ways we could be collecting data passively. on sleep, on, anxiety levels, daily mood trackers. I mean, there's things that we could be doing to try to really get much more nuanced into outcomes that I'm really excited about.
Yeah, a lot of speaking the same kinds of challenges. So, it's not just about collecting the data. The PHQ and the GAD-7 is what we've moved to. We used to use the DOS-21 because we were very academic when we started. But PHQ, GAD-7, and Therapeutic Alliance as a proxy measure. So one of the often discussed, debated studies is about the fact that you can use multiple modalities, but if the Therapeutic Alliance is really strong with the therapist, you can drive better outcomes. And so as a proxy measure in the beginning, we are collecting how strong is your alliance, and there's dimensions that are very interesting. But to the point, incorporating that data in a way that a therapist can see it, and then therefore you get it, okay, your patient's not responding, what do you do about it, is also complex. And to speak to the systems, Kate, you're just, it's PTSD because we shut down our practice for 3 days to move to a system that we built ourselves to actually report the data in a thoughtful way. And that takes work because it didn't exist naturally off the shelf. I guess just the last thing I'd say is with wearables, we checked it out. I want there to be something. Certainly surveys aren't great. Actually, we just spoke to the board about how sometimes clients underreport, so you don't get accurate data on the PHQ. But I'm a little more old school. Until we know, we're going to trust.
Absolutely.
We're going to trust clinician judgment and be more cautious about relying on too much of the wrong data potentially. But
so would you say that part of it is advancing? So if I think about it, like from what I've experienced, it's just advancing. So we talk about the PHQ-9 and the PHQ-2 and the GAD-7 and all those, but just out of your experience, a lot of it is just getting the adoption and the consistent measurement and the reporting of those things. Like doing something that basic would actually be semi-revolutionary in the space.
I was going to add that I feel very grateful at PsychHub that we have a scientific advisory board, and we do have the chief medical officers of behavioral health of all the national payers, of which Cigna and Optum are on, and the VA. And I'll say it is fascinating watching all of them work together, because this is a common problem. And I always say it's not PsychHub centric, but they are working on quality outcome measures. What are we actually going to use, right? So it's like, what is the, how frequent, and because otherwise it doesn't really work if Optum does it one way and Aetna does it another, and Centene does it different than Cigna, or Humana. So at least I'm really hopeful we're making really good progress, that we're going to be able to come up with something, at least as Eva said, a baseline, start collecting something. And it's a phased approach. So it's a journey. I do really think as a whole, it is a beautiful thing to watch everybody coming together for a greater good. It just elevates the whole space from mental wellness, as you were saying, to, just really more of a practice.
It's hard, but not impossible. Like after a year with Anthem, we've been able to demonstrate 30% reductions in anxiety, 50% reductions in depression, and just having a consistent measure and practices around it. We can do that in a fully employed process. It's harder in a network, but we believe that it should be more universally adopted. So
I'm really grateful we're moving, that everybody agrees that we need to move away from these subjective measurements, because Archana, if you don't remember, maybe 2018, it was like, no, these measurements are standard. They're the gold standard. We're not moving away from them. And and it was just like, well, wait a second, we need to move toward objective measurements. And we are, we're digitizing everything. But it sounds like we're still on the road of trying to identify those objective measures. So I want to ask Sandeep, because you said something really interesting about how you are measuring the relationship between the therapist and the patient. Did you say that? That's really something that you are honing in on. So how are you doing that?
And this is hot off the press. This is why we switched to EMRs and what we did. I will admit that this is, our clinical leader has an inventory of questions that are proxies for Therapeutic Alliance, that are dimensions that are kind of used in the research. Are we aligned on the goals for treatment? Do I feel that accurately supported by the therapist? There's about 4 or 5 questions that we can ask, that we would ask at session 3 and then episodically in the treatment, that are kind of important for us to get a read on, not to evaluate the therapist, but potentially see if there's a need for a rematch, or if there might be data that the therapist might use that might benefit them in their treatment with clients.
But you're saying that if there is an alliance, that is proxy for progress being made because there is a relationship that's being established between the
It's a leading indicator. If you don't trust your therapist, you're not going to make much progress regardless of what intervention that therapist is aware of. And so that is a kind of necessary and important first step.
Is that, so can I query you on the EHR? Did you do a home build, or is that the Teridium kind of solution on Therapeutic Alliance that you went with third party?
It's a customization of a tool called Welkin that was originally built for coaching that we've adapted for the purposes of mental health.
So I wanted to also ask all of you, because you have the network of providers and almost like solutions, improving access. Do you look at point solutions that are being sold directly to the employers, whether it's in the sleep space or BetterHelp or talk space or other types of solutions? Do you look at that as a potential for like integrating into your offering, or something that creates more noise for data and maybe confuses the end user, which is the patient? And that could be like, I'll start with you, Kate, because I think you also have care like on your premise, and you're also serving the employers too in a way. So do you see that conflicting sometimes when they do have solutions that are fighting with each other or giving the same kind of overlap?
Yeah, we do hear that, that there's a lot of different, and I've experienced it as well, actually, as a payer. There are a lot of different solutions out there. Several are very focused, very specific. They serve a very specific population. And so then, yes, it's hard to pull them together into one seamless continuum to address the full spectrum of mental health and substance use disorders. And absolutely, it can be really confusing for patients or employees who are, know that they need support, aren't yet sure what type of support to know exactly where to go. And so I think that's actually a major opportunity that we have, to be very clear about, what is the spectrum of opportunity here? How do each of these solutions fit together into something that's cohesive and easily interpreted by patients and their families?
And then Eva, do you notice that, because I almost consider like you are a more horizontal solution, and these are kind of verticals that you can integrate or confuse the end user in a way.
Yeah, so it's interesting because they show up in two different ways. So it depends on which door they walk through. So sometimes they'll walk through the employer door and say, I'm a vendor, I'm a point solution, buy me as a point solution.
Yep.
But if you think it's fundamentally what they're trying to solve, it's, I want to solve access to care for a specific area. So actually, when I look at them, oftentimes I look at it and say, well, I see you as a provider. I don't see you as a vendor. I see you as a provider. So I do partner with you and I do bring you in because you meet a very specific need. And it's funny because sometimes a lot of employers come to me and say, but I don't understand. Like, why don't you have a bake-off here between this and this? And I'm like, well, it's no different than if I'm a medical, like, so let's say that I am doing I have medical care. And I don't say, well, gosh, why did you choose, like, you said you wanted an open access plan. Why did I didn't say you had to go to Baptist or Methodist. I provided options because that's what I look to do. So it's a really interesting mind shift, I think, for a lot of employers, because when you have these, what I consider to be providers knocking on the door as a vendor, it can get really confusing. And so I think we're all kind of finding our way in this world. When I do think about, different types of companies where I think have a higher probability of success and ongoing sustainment, those who can straddle that world, who can ultimately also be a provider, have much more opportunity for sustainability, growth, long-term, as opposed to, I think, when you play almost exclusively in the vendor space, it's way harder to scale, in my opinion.
Awesome. And then Marjorie, what are you seeing in your space? A lot of point solution play, or is it more kind of generalist?
I mean, I think it's probably a little bit different for us, but I still go back to the sense that everybody might need a different type of care, and different things resonate with different people. And so for some people, a digital CBT tool works great. And not to say that Sandeep's, the connection with the therapist doesn't matter, but for some people, they just want it to be digitally. So I think that we're in a new time, and yeah, there is sometimes a lot of noise, but I'm also like, in some ways, I'm really appreciative that there's so much emphasis on mental health. It's a little bit hard being in behavioral health for my whole career, and then you see all these new people come out of nowhere, and it's a little bit like, whoa, but with that said, technology is really, really cool. We're doing really different kinds of things. And, we're at PsychHub focused on moving behavioral health providers from generalists to specialists, certifying them into these specialties. And then we have our mental health ally, where we're really trying to take just everyday people and elevate them up to offer support. And I think about what Eva said, because we do on the company side, we usually come in through the EAP, but sometimes the companies come to us. So we're like a vendor, if you will, of education, but then we also are training the provider. So I don't know. I think that my hope is that we vet out the good products and good solutions, and the rest of them kind of go away. But whether someone uses Calm or Headspace, it's whatever works for you. That's my 2 cents.
So along the same lines, especially since we are with you at this point, when you do provide certifications to your specialists and then your constituents in a way, do you notice it impacts the reimbursement because they're more qualified, or like they have more credibility or credentials?
Yes, that's exactly what we're working on. And so I'm glad you asked that question, because our whole point is, that's why we have that board, right? It's getting the outcomes, because it matters to us, because we want to be able to show that providers are giving better care, and patients or clients or members are getting better outcomes. How they collect that, whatever measurement-based care platform they use, we don't care, right? It's whatever they want to use, but we are seeing unbelievable differences. I mean, we're seeing huge engagement, and I don't want to overtake this, but a lot of where we're seeing a better outcome is so much of our learning solutions are, yes, we're training the provider, but then we have all these solutions for the patient. So they get homework videos to watch to reinforce skills. They get, so they're working in between session. So our outcomes, we're really not at this point totally sure if they're working as well because the provider's more engaged. The client's more engaged, or the provider's doing more precision care. And by the way, when you educate the patient of what the care is going to look like, then you really are pushing the provider to have more fidelity to the model, because your client knows it's 6 stages. This is what's going to happen in your session today. And then here's the homework from it. So we are seeing incredible outcomes, but yet we're not quite sure. Yeah, we don't know. We haven't seen it long enough yet to tell which side of it is, or is it just both? Are we just seeing a better alliance because the technology or the education is helping in between? Does that help? And yes, we want better out. Our whole thing always is, let's get the providers paid more who are delivering better care. And that's why we have to be able to show that care, which is why everyone is saying the same thing. It's the how are we measuring that? What are we using? What does that count? What does it look like? Because it's really confusing. The reason why it's not being done is not because there's resistance from the payers. I really feel like they want to do it. It's very confusing, and it's not an easy solution. And then Sandeep said it right from the beginning. The feedback loop back to the payers is also a problem. So like Kate said, the technology is not there. So we're collecting the outcomes, and it's good. It's going back to the provider, and they're seeing it, and they're able to tell very simply, right? Like the GATS page Q9. But then how do we get that information back? So, and I will say to give Optum, Optum, Aetna, and Anthem as well, they are turning on these codes where providers can actually get paid more for collecting these outcomes. 96127 is the code. And so that's helping. We're seeing that helping a lot too. So I think that's gonna change it as well. So that's my hope, is all of our hope, right? We can start getting better outcomes and being able to kind of tell preferred providers.
Did anybody want to respond to that?
No, I was just thanking her for sharing the insights into education aspect of it.
Okay, I wanted to open this up because we do have a question, and I want to remind everyone to go ahead and put, raise your hand or put a question in the Q&A, and you can direct this to anyone or everyone. So we have a question here directed to everyone. What are your thoughts on bringing asynchronous assessment into mental health psychiatry as a standard of care? It has, of course, been highly successful in other verticals. So thoughts on asynchronous assessment into psychiatry, mental health, but obviously also how do we pay for that too?
Can I gain clarity on asynchronous assessment? Because
I can explain. The synchronous is like what we're doing right now. We have synchronized our time in the same way when the patient is meeting their therapist. That's a synchronized visit. The asynchronous is like texting. So the provider can text in these questions in times when they're not seeing the individual and gather that data occasionally. And a lot of people do that. Like, for example, even Amazon does these asynchronous surveys sometimes. Are you enjoying our app or whatever it is? So we have definitely adopted asynchronous communication in general, surveys included, in so many lines of services. Primary care for sure, dermatology, orthopedics. There's a lot that is being utilized. Mental health is hard.
Well, that's where I thought that's how we were defining it. I mean, ideally, when we're talking about these surveys, the PHQ-9 and GAD-7, absolutely, they can, and it would be helpful if they were done asynchronously, right? So I'm coming up for my appointment, in a day or two, I fill it out. It gets into the EHR. By the time I see my clinician, the clinician has the scale and the trend over time. Like, that would be ideal. And then certainly there is lots of, informal texting as part of treatment, which is helpful for people. I think, one challenge comes in, it is helpful to see people. And part of our training is around, reading a lot into, and actually that was one thing I was going to add to the telehealth. Now we actually even get to see into people's environments, right? As well as actually see their affect and things like that. And so having some sort of touch base where we do have some synchronous is important, but I think asynchronous is absolutely a critical part of the following the outcomes as well as connecting in between visits.
Yeah, I very much agree that even beyond outcomes, you see it sometimes in the digital space where there's some mobile apps that do asynchronous but light touch assessments, like how are you feeling today, and then deploy digital interventions. That might be useful adjunctively to treatment. And it reminds me of primary care. I came from One Medical where we did Treat Me Now. We had like specific tools that we use adjunctively to treatment in person for lower acuity kind of things. I think as an analogy, it works. There's nothing we do right now, but I think it could be interesting over time.
I think that's a great point. I think there is a lot of promise with digital CBT, et cetera, because for both low acuity or low complexity, where maybe that's all that's needed, all the way to even more severe conditions where it gives you many more touch points in between those face-to-face visits, which could only intensify the dose basically of the treatment that people are receiving. So I think there's a lot of promise there as well.
So let's go and talk about 2019, even though we never want to go back to 2019, but we did a lot of in-person, and I don't want to discount in-person as though that's passé and we're never doing it anymore. But I think we can come back to it and say, hey, it could even be better. And so, I'd love everyone's thoughts on what does in-person look like, because it's still very relevant and we still want to be in the same room with people. I mean, I certainly hope in November I get to actually shake hands with everybody, even though I love looking at everyone's background, which is our sponsor background. But Sandeep, what do you think about when we get back to in-person, how you're going to change it up and make it better?
Yeah, it's a great question. look, I don't think that you can put the, whatever the analogy is, cat back in the bag, or I don't know, but we can't go back to the way we were. Someone has to correct me, but in the sense that I think not only do clients prefer having a mix of digital and the convenience, but therapists do, having a little more flexibility, or providers like that flexibility of being able to work from home sometimes. With that said, I think we saw, particularly with our employees, it's hard not to have connection points with your colleagues. And so I think it's actually useful for therapists to have the ability to kind of flexibly use in person when required, maybe in the beginning to establish relationships with clients, and then over time, as you get that comfort level, to be able to work for certain high acuity where you feel more comfort in person. I think that's where we'll use it, and just client preference. My own random arbitrary guess suggests that, even though we're fully in person, about 75 to 80% of our care will probably be virtual post the pandemic, but there will still be a toehold in person. And even if as a convening point for providers to discuss kvetch and help support each other. Cat in the bag, I'm going to stick with that.
That's right. Great idiom.
Maybe the screen in the bag or something. The screen has come out and has become the doctor. I do feel, as a practicing clinician, and sorry about my dog in the background because it's work life here. I think we have to consider the kind of care, almost like how we escalate care in a patient's journey. So some things don't need an antibiotic, some things need an antibiotic, some things need chemotherapy, or going to a little bit more. So analyzing that in a little bit less way, asynchronous could be your non-therapeutic, non-medicated thing, and then your synchronous visit via Zoom or other kind of video partners could be your second level. These are doses of treatment that escalate as based on like whatever the patient needs are. So this is when we're truly personalizing care to the individual and their needs, and scaling our providers for sure.
It would be a complete game changer if we could do that, and also addresses workforce shortages, right? Because right now our system is really inefficient in that, and some of it again is based on how we pay for care. But you've got licensed like clinicians that oftentimes are seeing people with mild conditions potentially, and then you don't have access for people with really severe and complex conditions, and so it's a really poorly matched system according to need. And so if we could be much more proactive and thoughtful about what is the need of that this person is presenting with, or the family is presenting with, and then how do we match that right resource? I think it would actually address a lot of our workforce shortages, just doing that.
And I would love to put a data scientist behind it to kind of make it more automated. So then we are not the ones deciding as clinicians or providers saying, hey, you need this. Instead, the system tells us what the need is.
I think this is a little bit of a commercial for Neuroflow, not to tee them up, but they are sponsored, and they also provide that collaborative software that tries to integrate between primary care physician and all the care providers. But let's talk about that. How are we doing in terms of helping the primary care physician? Because we all know the statistics, like 70% of the antidepressants are prescribed by the primary care physician. Something's wrong there. They should be the quarterback, being able to have a sort of a support team. How are we integrating better with the primary care physician who's the gateway to all these patients?
Well, I'm going to let Kate take that because I know that's her passion, but I will say that PsychHub has partnered with Neuroflow on educational content for collaborative care. And we're doing it in partnership with Magellan, a payer that's not on here, but we are excited about that. It's the first time we're in that space of primary care. So it'll be interesting for us to see kind of what it looks like. But it's fun. I'm going to give it to Kate, but I also just have to say that I really appreciate this conversation because you're calling it the future of behavioral health, mental health, and we're talking about it. And it's really exciting to see that some of these things that you used to talk about, now they're actually here, and we get to talk about like you were just talking about that perfect kind of where this could go. So I love the conversation. And Kate, I'm going to put you on the spot because I know collaborative care is.
Yes, I do get very excited. It is one of my favorite topics. So it's an evidence-based method for delivering behavioral health treatment within primary care. Been around for about 20 years, came out of the University of Washington. So while yes, it's the future, it's been around for a while. So there's another part of me that's like, why can't we just do this? But it also goes back to the points that we were making before, that if you think about, a population, or you think about mental health and substance use on a spectrum, honestly, the bulk, like 75% of mental health conditions are actually mild to moderate. And so if we could, do a better job of identifying those mild to moderate conditions, and enable and empower primary care providers to address those conditions, also use telehealth, use digital means to address those conditions, then you're reserving your limited supply of specialists to focus in on that patient population that has more severe and complex conditions where they're uniquely trained to treat. And so integrated care is really magnifies the behavioral health workforce and helps us address a broader portion of the population. But the key is that they need the support. Primary care providers have so much on their plates, and throwing this over as yet another thing is not okay. It's really got to be a really thoughtful and integrated approach.
And are you paying for that somehow? I mean, how is the payment models changed?
Yeah, so there are collaborative care codes. So these are basically like CPT fee-for-service codes that can be billed through Medicare and several commercial payers, and several states as well are paying for them. The game changer again would be to drop all of those fee-for-service codes and really go towards population-based payments, where we're paying health systems, we're paying provider systems to just take care of people. And integrated care is one way, again, to maximize, the access to care, but also the health and cost outcomes.
Now, as we've met with some different, I totally agree with everything that you're saying, Kate. It's so true. And when we've actually talked with different medical providers, it's really interesting, because if I think about the curve of adoption and integration, you almost start with, okay, they're in the same network. What does that mean? They don't practice together. It's completely fragmented. And there's this thought that says, okay, well, if I just have a behaviorist in my office, if there's just a door that they're in, and they almost function, you can imagine like being in an apartment building, right? Just because I'm in someone's apartment building doesn't mean I go to them, I look to them, they're my neighbor, they're just in the same apartment building. And so there's almost this sense of, all right, well, if we show up together, oh, well, it doesn't work. So this whole integrated model doesn't work, but that's not true. The reality is you actually have to have them as a part. So stop being an apartment building, be a house as a family, start functioning like that. That's where you'll see. And so it's almost this value chain of fragmentation. I do a little bit, I get very little return, but man, when I actually integrate that behaviorist in a really meaningful way, my return magnifies multiple times over. And so it's just a really interesting piece, because you see people trying to take baby steps. And when you take the baby steps, your return is so little that you actually have to go from that, we're not together, to an apartment building, skip that, and actually say, how can we try and function as a family? And it takes time, and it's not easy. There's definitely learning and practice patterns to be worked out. It's a really exciting space, but it's not easy.
I absolutely agree with you. I do see patients through Crossover Health, and I don't know if you guys know Crossover Health, which is a company that is an integrative primary care company that does have primary care, registered nurse, mental behavioral health provider, physical therapist, chiropractor, and health coach sitting in one room, literally. And so when care happens, it's so coordinated and together that everybody knows everybody's patient. And as a clinician, my health outcome is better because I'm a mental health provider. Because each person with depression gets a referral into mental health. Each person with hypertension, a cardiovascular condition, we know these comorbid conditions. And then I'm less likely to use medications for conditions that are affecting efficacy for the individual who's a high-performing individual in a company, and they need to be present, fully functional. And even though as a provider, I may not want to prescribe the medication, but the patient has no access to mental behavioral health and they need to function, work-life balance needs to happen. And so there is either provider who's not incentivized, or patient not incentivized to actually go through therapy because it's fragmented. So models like those will work. I hope more happen.
Yeah, it's actually one thing that virtual will help, because I recall in primary care, one of the hard parts in physical is there's actually different workflows, different operational complexity. It can work inside of employer on-site models, but in fee-for-service, it was a lot harder back in 2016 when I was looking at integrating primary care and behavioral health. But thankfully, between the codes and virtual, I think it's, hopefully going to be a lot easier going forward.
One thing, Sandeep, one thing we did do is a real-time warm transfer. So just like we're in a Zoom setting, I'm talking to a patient. I pinged my mental behavioral health person saying, are you free? I got a patient for you. She jumps in on the Zoom call and I leave, make her the host. And that's how it happens. Like it's that magical in real time. And so if you're able to develop maybe even partnerships and pilots in that way, that you could quickly check in and make that transfer happen, that's when patients are more likely, because it's coming from trusted source real time when they need it, how they need it. So
that is so cool that you can do that on Zoom. I never thought about it. Back in the day when I was in private practice, I was in a medical system. It was kind of one of these private practices with one of every specialty, right? There was primary care and orthopedist, cardiologist, and I was the token therapist. But it was exactly like that. They would come and walk over and knock on the door, and it wasn't it wasn't a formal collaborative care model, but it was really like a holistic approach. But I never thought, the whole time I was thinking, how would this work on virtual? But that's really cool that you just, would bring them into Zoom and go from there.
I mean, we have run our emergency drills on Zoom, believe it or not, and we actually created models around so it's possible. Actually, Zoom makes a lot of things possible, or video does. So, and it's measurable too, by the way, from value-based perspective,
Yeah, barring another COVID or pandemic to force change, I hear everybody talking about, that we have to move toward value-based care. We have to get rid of fee-for-service in order to have collaborative care. So what needs to be done? Because we need collaborative care. Clearly, everybody agrees. So what needs to be done to move away from fee-for-service?
I'm a little more cautious because I think, first of all, we need to be spending more on mental health generally. And it's not necessarily the case to me that every dollar of mental health spend is going to result in a dollar of medical cost reduction. And that we have to grapple with the fact that we just ought to provide the services. And I think the trickiest part, well, you need to have providers of scale. I think the trickiest part is how do we really understand length of treatment in a way that would be appropriate, clinically appropriate. I think that's been an area of struggle. When you think about population payments, base payments, you can't get past fee-for-service until you can create a clear rubric, I think, to discuss when to terminate. And that's a really hard problem that we're not there yet. At least we personally are not there yet, ready to solve.
What do you guys think?
I'm more aggressive. I'm done with fee-for-service. It is a very hard way to practice. Again, a lot of times I use this in description a lot, where oftentimes the most important thing I do as a clinician is that phone call. After prescribing Prozac, for example, you start Prozac, you always have to start at a low dose. Some people have a lot of side effects. Some people feel nothing. It really helps. You make that phone call a week later, ask how it's going. If people are feeling nothing, you say, no problem, just keep taking the medicine. Or they're having some side effects, you can lower the dose. Those sort of micro touches are incredibly important, but really aren't funded in a basic fee-for-service environment. And so you can't, if you're running a practice, you can't do that kind of sort of in between the visit work at scale. And it's critical. That's some of the most, or another is, I'm a child psychiatrist. If I go visit the school and advocate for a child, that's probably the most impactful thing I could do as a clinician in terms of that child's health, not paid for, in terms of fee-for-service. And so, so I think, the question was, what do we need to do? One is develop the models. And there has been some work in there. There's P-Code was developed by, ASAM. We developed some models at Blue Cross North Carolina, where I came before I came to Optum. But that's key, is actually advancing the payment. honestly, payers have to move forward in their claim system. So, to be able to pay a population-based monthly payment, it takes a lot of changes actually to the claim system. And so we have to be able to do that. And we've got to advance, our understanding of outcomes and like how do outcomes impact, how do they correlate with, how should they correlate with payment? That's a whole area of research that we've got to move on. But I'm firmly a believer that I don't think we need to let perfection get in the way of moving forward. And I think fee-for-service is so challenging. Actually, one last thing, it also creates this mismatch, right? Because if I'm a clinician, if I'm a clinic, and my payment requires me to see a patient face-to-face or by telehealth in order to treat them, then I'm only going to focus on those patients, right, that are showing up and presenting for appointments. We know with people with mental health and substance use conditions, the condition themselves makes it hard to actually, show up at an appointment and get off work and do all the, or if you're working or even if you're not working, it's hard to actually get to appointments on time. And so those are the patients that often get fired in the current system because they're not reliably showing up. And that's the most vulnerable patient population we have. And that's the group that goes without care and, ends up, waiting until they get into crisis. And so I think changing to where, I as a provider am responsible for this population and I don't have to be bound to people who just show up for clinic. That's a game changer.
Yeah, I would add to, so go ahead, Marjorie.
No, go.
So I was going to say, so I appreciate, Kate, everything you're saying makes total sense. And I think there's this philosophical alignment. So my background is I'm an actuary. And so when I think about what ends up happening is when you get people and wanting to adopt and say, okay, ultimately, like the hard dollars and cents of it comes into play to say, and Kate mentioned it, but I would really want to punctuate it. So two pieces. Number one, proving the outcome so you can demonstrate the value. Like it's actually been a lot of fun working at different things. We were doing some research lately around the cost of an episode of care. So everybody focuses on the fee-for-service widget, but when you start really looking at the episode of care, what does that episode of care look like? What's the cost of that look like? When you think about doing value-based reimbursement, what you have to really be able to prepare to do is say, what is that and what's my corresponding outcome? So that's kind of number one. The other part is we have a fee-for-service system and it's afraid of change. So think about, so let's talk January 2020. If we were having a conversation about telehealth and the value of virtual care, we would be having this conversation. Why is the adoption only 1% to 2%? It's really low. People are uncomfortable. It's not as good. There is no, the efficacy is limited. We don't have the research. We don't have blah, 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 blah. And here we are, like accelerated like that. So I think there's some pieces that there's gonna have to come apart in the system upon which we go, okay, Kate's going to be doing it with Optum. I'm going to be doing it with Cigna and Evernorth, which is we want to advance it. But I think there is this whole piece on advancing it fast is going to require a level of change in the system. That's going to require practice change, thinking change, value change, how we perceive, like I was mentioned earlier, that whole concept of behavioral health being a wellness thing versus, oh, wow, when I pay for behavioral health, I actually get real medical value for it. I mean, proving all that out becomes really important. So that dollars and cents piece has to come into play to get other people, because I think from a practice perspective, you nailed it, Kate, and Sandeep, you totally hit it from what it means. Getting that dollars and cents in line is going to become really important to accelerate adoption and get your CFOs and others to buy in.
We need that forcing function, Eva, to get everybody on board. I want to ask something a little bit more pragmatic. So I think you work with Happify Health. Is that right, Eva? But Cigna works with Happify Health. So what do you look at? What are some of the outcomes they're providing? What are some of the measurements tools they've been able to, they're offering that give you comfort and confidence to support their product?
Yeah, so when you think about Happify, and it goes back to that spectrum. So if the conversation we had earlier really focused on, there's kind of this low acuity, almost subclinical, that where can you have digital only interventions come into play? And so number one, when we think about working with them, a lot of it is these same measurements. It's that asynchronous piece. It's measuring the difference in the measuring in difference in the different scales that they use. I can't tell you exactly what scales they use off the top of my head, but they'll do that. And then we also marry it up with, okay, if for someone who's had an intervention, how can I now, to the dollars and cents part, say, if someone's had an intervention, what's the medical cost value that I can see, or the pharmacy value, or the difference that it's made? So when I think about that, Bambi, for me, a lot of it is that they're using the tools that they have in place. But to be really clear, like for us, a lot of Happify is the subclinical. So it's those digital tools to help stop or intervene before I might have to go on and progress into more advanced levels of care.
Sure. So a reduction in claims data, but it would be difficult for people, for instance, I think Kate mentioned that most people are dealing with mild anxiety. They don't really have the claims data until it becomes acute, right? And so how do you even measure a reduction in something that they've never had?
So I'll just clarify before Kate goes on. When I say claims data, I'm not talking about behavioral claims. I'm talking about the full spectrum. So like that's the one thing to be really careful of, is that full spectrum of pharmacy, medical, behavioral, it goes in. Sorry, Kate, I'll let you take it from.
No, that's a great point. And then also the other important thing is that a lot of the times people, the medical expenses are high because people are using inpatient or emergency departments, and they're not accessing outpatient at all. And so if you're trying to advocate or do the analysis around an outpatient intervention, you're basically comparing it to no care, a lot of no care, at least in the outpatient setting.
No, that is a great point. So great point. Yes, because obviously mental being, having the right frame of mind really enables you to make the right lifestyle decisions. Right. So reduction in care.
One thing I will say, I know we're almost at time. I agree with Sandeep though that we don't need to be held to always be cost saving. We don't require that of other medical conditions that in order to treat them or expand access that they have to somehow demonstrate cost savings. And so I think it's really important to be, yes, we have to be financially responsible and do the analysis, but also important to look at other outcomes as well that are important.
Do you, on that front, Kate, do you merge your health outcome ever with your mental health outcomes? Like physical health outcomes with your mental health?
So definitely you would want to show that's our priority, is that you show not only improvement in the depression, the PHQ-9 score, the diabetes management, the cardiovascular management as well.
Yeah. There's a question.
And sometimes we also get to this question around, well, wait a second, shouldn't I see like too many people are getting behavioral care now? Like I'll hear that every now and again that, too many, like just people who aren't in the space will say, oh my gosh, we're spending this money. We have too many people getting behavioral care now. It's like, no. The gap, we still have this massive gap between the people who have needs and are getting care. That opportunity continues to be tremendous. And I think we take, at least I know in the behavioral space, we tend to take for granted that people know that, but a lot of people who don't live in this space don't realize that that's actually the case.
Well, and then there's several reasons why, like we don't identify upstream. We do not identify kids developing this a lot earlier because pediatric care is so driven by vaccines and sickness. There is no regular check-in with pediatrician that happens in which like there's any focus on mental behavioral health. So we see people already kind of set in their diagnoses much later in the process, and hence there is a big backlog. We also we have not designed lives in general to be self-resilient and also dealing with stress in a positive way, and the work culture that kind of responds to it. So there is a lot of other things that we could be doing differently, but there is a huge backlog, and it's called, we call it the silent pandemic of our time, which got unmasked during the pandemic.
I want to get to this question. It's really one question. From an entrepreneur, I believe, who is wondering why and who's responsible for paying for these measurement-based tools. I guess he's assuming that mainly it's on the onus or the shoulders of providers, and why is that the case? And then, so who should be paying for these measurement-based tools? And then how are we rewarding providers for using them? And I think Marjorie sort of alluded to that, sort of how do you reward providers for using a better measurement tool, being cognizant of constantly measuring their activity. I guess this is to everyone.
There is reimbursement, so you can bill a CPT code for the screeners. I think it might be $2.50 for reimbursement, but it is there. There's a CPT code for it. One thing that again, we did in where I was at Blue Cross North Carolina, and some payers are doing, is actually giving the infrastructure to providers. So that's what we did. We gave them the sort of electronic infrastructure to be able to measure these at scale, and we gave it free. We said, please just use it. And then they used that to report up. And I think there's an argument for that, especially these are investments that we need to make, in healthcare, and also that payers can do on a regional basis. And so I think that's important.
So I think we got to wrap this up soon. So I'm going to leave with a light question, and then we'll wrap it up with maybe more of a futuristic question. So the light question we didn't ask in the beginning is, what is your mental health hack? So quickly around the board, Sandeep, what's your mental health hack?
So in distress, I have a therapist. I see a coach from time to time, but the one I'll choose is, in moments of the ups and downs of entrepreneurship, there's like little micro sizes. So just like a quick, 15 push-ups or something, just to get on my own head. I do that from time to time.
And Kate?
Nice.
Sorry, there's some reason my husband turned on this really loud music. I'll be right.
The party has started already at her place.
So Eva, or maybe Kate, you're back?
I am, sorry, I'm not, that's never happened before. What was the question?
What is your mental health hack? What do you do to help with your mental resilience?
Mine is being with my family and then trying to exercise, but that is I am happiest when I have space and time for exercise, and that's been that's the challenge though.
And then Eva?
I think for me, I have a morning routine that's just really time for me. And probably the most important part of it is reflecting on 4 things from the prior day that I'm thankful for.
Oh, that's great.
That's amazing.
Time of gratitude. That's awesome. Marjorie?
I mean, I certainly haven't figured it out. So let me just go be right and transparent is, it's tough, as Sandeep knows, as an entrepreneur, and then in mental health, and then online ed and all of it. But I am very strict with my morning routine, as well as like Eva. I wake up and I work out every morning, and sometimes it's really hard, but to find the time, but I do it and if I don't, I'm very I get upset because I feel like it's my only time. And then I'm a big Peloton junkie, but they really get you to do the gratitude at the end of it. And that got me into a really good habit of doing my gratitude every day. And so even when I don't do it, I kind of force myself. And then that centers me too about that day and what I need to do. Other than that, that's like probably the best. And then the rest of the day, it just kind of goes like this. No, it's all good. It's just hard, right? These are hard times.
You, Archana, of course.
Oh, I need to answer too. Mine. I have on my calendar out of office from 4:30 in the morning until 7. And that's kind of my me time, in which I learn new things intentionally. I definitely go to Stanford Dish every morning for my walk, and amazing. It's meditative, but it's hike, and I walk around that. So good elevation, being with nature, and then definitely end the day with a hobby. I love singing, so that's kind of my end of the day.
That's great.
How about you?
And I mentioned it too, Archana, you're my therapist. Once a week. No,
You're my therapist too.
I do have my morning ritual as well, which I fill myself with gratitude. I put on worship music and I pray, actually. So I like to do that. I do work out, but I tweak my back. So that's more of a sign of my age, but I try to do that as well. The exercise is a good thing. So last question is, okay, In 2019, we had a different conversation about mental health. Obviously, telehealth was huge in accelerating a lot of future adoption forward. So if we're to have this conversation, I'm not going to say next year, but a year, 2 years from now, so 2023, what does mental and behavioral health look like? So let's start with you, Sandeep.
I'm thrown by Archana singing. I was an a cappella musician in college, so next time I see you, we'll beatbox or something. What does it look like in 2 years? 2 years is not far enough out. I think it's going to look pretty similar, but with more, hopefully more coverage and more use of measurement, and hopefully starting to evolve into some of these episode-based payments and population payments being done more frequently. Yeah, but it's going to be a long journey, I think, to where we need to head.
Okay, Marjorie.
I mean, I'd like to see people get matched if they have depression or whatever they might have, get matched to therapists who are using those evidence-based interventions. And I love what we talked about today about that more personalized care, that some people might want to be virtual. I just loved Eva's story about her daughter in her bedroom, and it just, to me, that makes that really calls a great argument of why that might work for some people, and some people want to be in person, and that we don't see the difference or judge the difference. It's whatever works for people. And of course, collecting outcomes as well.
Great. Eva?
I think mine's gonna be really practical. Ease of access to care. More people who say, I find getting care easily. I know where to go. I know what it looks like. And to me, it'll be measured in the percent of population getting care. If I know what I think the diagnosable population is, I should see meaningful changes year after year and that number going up.
Great. And Kate?
I think they hit my wish list, everyone. Yeah, the things that come to mind are really democratizing care, like turn it on its head, make this a system that people want to be a part of, and where yeah, it's easy to access and easy to engage, and we really take it necessarily out of the clinics and put it really towards where people want to receive care in a way that's convenient for them.
Archana, did you want to add your
I wish exactly what, like the access of care, and finding more methods of creating mental health and behavioral health ambassadors, because I do feel that we cannot depend on clinicians and coaches. We might need to find patients like me and success stories around people who can be inspirational and can become almost kind of mental health mentors. Because exactly what Eva did is like shared her story, and it lighted up a bulb, like either an idea or adoption. And so people who have success stories, I know NAMI does a lot of this work, but it's so siloed and stigmatized in a way because it's coming from NAMI. But it's almost like we could create cohorts of populations that could have these well-being ambassadors that could drive change and improve access.
We have mental health allies. We're getting allies throughout the country. So, but It's so true. And it doesn't matter where or how they learn or what they resonate with. I so agree. It's normalizing it.
Yeah.
Well,
everybody has a story and they can share it.
Yeah, and I think that we're already sort of halfway there in terms of turning things on their head, Kate, as you said, because I think it's also our perception of human nature, where I think we all thought that we were so awesome, and now I think everybody's realizing we're actually quite broken and we kind of need help. And we don't need, as to echo what everybody else is saying, it's not just clinicians, but it's remember, family, friends, neighborhoods. So everybody waking up to this challenge of supporting each other. So with that, thank you so much, everyone, for a robust discussion. We are going to have this recorded. Also, we are having another breakout session July 14th, a little bit different. We're going to we're just not going to have the payers there. No, guys, these are B2C companies. These are going direct to consumers and seeing which, our consumers actually paying for the services, these valuable services. So anyway, with that, thank you, everyone.
Yeah.
For a great, robust discussion. And I'll put this online, and have an amazing day, rest of the day.
Great
Thank
conversation.
you.
Thank you very much.
Yeah.